round of applause for the IHA. This crew putting this together. I mean, really nice job. Thank you, Shannon. I think she's in the other room, but this is our first crew seminar. We're having a great time, so that was fun. Also, I do want to just extend a thank you to pretty much every other doc that talked before me. You know, they basically, through their hard work, through their efforts, through their research, you know, they've basically paved a way for hyperbaric oxygen to get to the place where it is today. And I just want to give a thank you to all those doctors. Please, another round of applause. You know, it's allowing us to have this conference. It's allowing me to stand here and have that conversation. So, you know, debt of gratitude to those folks. So, as we get started, anybody else really excited about the mitochondria besides me? Yeah. All right. Good. Let me see if this is working. Oh, this isn't working. Wrong button? The down button. Okay, that's a fun video. If you're ever bored and want to go to YouTube, it's a funny mitochondria song. Yeah. Yeah. All right, so some mitochondria facts, some things you probably already knew, some things you might not already know. But obviously the mitochondria is in charge of energy production. Without oxygen being present, you know, pretty inefficient system. All we have is glycolysis, and we're only making about 2 ATP. But in the presence of oxygen, using glucose, which we're going to talk about other substrates that we might burn for energy, but using glucose, again, depending on what you read, 32 to 36 ATP. So it's a much more efficient system when we have oxygen present. Some things you might not know about the mitochondria, it would be that it has its own genome. So it has 37 of its own genes, 13 of which are geared specifically towards oxidative phosphorylation. So it's able to learn from and adapt to the environment and actually make changes to itself based on that. And some of those changes include things down below, like changing its size, changing its shape, fusing together when necessary, increasing its density, as well as plays a huge role in apoptosis, which a lot of the other docs have mentioned earlier. We get our mitochondria from our mom. So sperm cells do have mitochondria, but they die off once the egg is fertilized. So for all you with mitochondria, say thanks, Mom. And we need ATP for everything. There's not a single thing that our body doesn't require energy to do. So every muscle contraction, every thought, every breathing, every synapse, every single thing that happens inside your body requires ATP, therefore requires some sort of mitochondrial function. Everything but red blood cells. Red blood cells do not have their own mitochondria. But every other cell needs mitochondria, it needs ATP synthesis on some level as its fuel for any energy production that we're doing. And it's a beautiful symphony, right? We don't even get energy from food, right? We don't actually get energy directly from our food. We actually have to take our food, our fat, our carbohydrates, our proteins, and we have to break those things down into substrates, pyruvate, right? And then we have to start passing electrons along, NADH, FADH2, and it's through that system, through that mitochondria, that we're actually creating, as Dr. Rosignol had mentioned, like a battery within the matrix of the mitochondria to create a process where we could create this ATP. And the only byproducts are a little bit of carbon dioxide and some water. And so it's really a beautiful process to understand and to be able to understand it so that therapeutically we can know how to make changes to it when needed. And so that's what we're going to talk about. I don't know why my slides are a little funny over here, but it says mitochondrial function. So what we're going to talk about today is how do we manipulate the environment? We know that mitochondria plays an enormous role in so many of the dysfunctions and the chronic illnesses in today's kids and today's adults. And so what factors can we put toward that mitochondria to change its environment so that it could learn to adapt? And if it could learn to adapt, could we then get higher percentages of ATP production and less consequences of the mitochondrial dysfunction? And so that's what we're going to talk about today. So this is my crew. Maybe you saw us walking around the boat. That's my kids. Levi in the blue vest, Wyatt in the white vest, Kaya in between me and Melissa. Melissa, also a chiropractor, we work together in our office. As you can see from their beautiful faces, they also get their mitochondria from their mother. But the reason we're here for me is this. You know, I'm sure most of you have heard a sentence something like this in your reading. And you all have your own stories. right? You all have your own experiences either with your own families or with patients and their families. And we know that illness today is skyrocketing. And we know that chronic illness, especially in kids, is at astronomical levels. And I have to say that it's in a room like this, with doctors like you, taking time out of your lives to learn things like hyperbaric oxygen, that I believe will make a difference in that story. And I hope to see that we can change this. So I am Dr. Jason Saunders. I am a chiropractor with Melissa, my wife, and we have 6 other chiropractors that work in our office. We specialize in a little bit of everything. We have 6 other docs, and so we do some functional medicine, we do functional neurology, we do pediatric, prenatal, postpartum, sports injuries. We have a functional neurologist. Did I say that out loud yet? And so, together what we're trying to do is we're trying to put together plans where we can handle a very large range of ages and a very large range of conditions that we're able to help. We also use other modalities like infrared, which we're going to be talking about today, nutrition, which we're going to be talking today, and hyperbaric, obviously, which we're going to be talking about today. We've been using HBOT in our office since 2009. We currently have 1 soft and 1 hard chamber in our office, and we also help patients with rentals or purchasing if they can't get to our office or it's not appropriate to do so. So we believe in HBOT. We believe that it plays a huge role in many of the conditions that you and I are seeing every day in our office. So here's our little bit of a roadmap that we're going to be going through. So we talked a little bit about mitochondria, why it's so important, how much fun it is to learn about. We're going to go into next chronic illness and chronic illness in the US. So, show of hands, do these look pretty familiar? These are pretty much the most common chronic illnesses that I think all of us are dealing with in our office. Some of us specialize in 1 or 2 of them. Some of us might see a variety of them. But at the end of the day, this is a list of all the chronic, not all, but most of the chronic illnesses that are plaguing the US. So heart disease, stroke, diabetes, Alzheimer's, neurotransmitter disorders, you could read the list. But, we're trying to have an impact. And as one of the docs, I think it was Dr. New earlier today, said, listen, when it comes down to it, yeah, they're inflammatory diseases, but it's a mitochondrial issue. If our mitochondria aren't able to make the energy they need to make or kill off cells when they're supposed to kill off our cells, the apoptosis, we're going to have a hard time managing inflammatory disease, and as a result, we're going to start getting lists of conditions like this. And so, how are things going so far? Let's say in the last 30 years, how are the rates of autoimmunity? Are they going up, going down, staying, right? Cancer, heart disease, stroke, you name it, right? So, with a lot of money, true or false, the US spends more money than any other country in the world on healthcare. True. So, it's not for lack of funding. But with best efforts in traditional medicine, we're seeing still enormous rates of all of these diseases. We're basically not making a great dent in this process, in my opinion. Last time I checked, I believe the US was 37th healthiest country. I can't name 37 other countries, period, let alone 37 that would actually deserve to be, in a state that they're healthier than that we are, given our education and our ability to influence that monetarily. So again, how are the trends going? In New Jersey, I remember not that long ago, autism I think was about 1 in 100. More recently, it was 1 in 59. Even more recently, it was 1 in 34 in kids and boys in New Jersey. Dementia, it's coming, right? 2050, it's supposedly 1 in 2 in all adults over 65. That's not old, right? These are diseases that, especially dementia and cancer, right? Depending on which type of cancer we're talking about, headed towards 1 in 4, diabetes 1 in 3. It's not like we're making a dent, and these things are coming quick, and they're coming fast, and they're coming hard at us. And I don't think in traditional medicine we're making the dent we need to make. And I think part of that, here, what's the first sign of a heart attack? Death. What else?
Chest pain.
Right? Chest pain, difficulty breathing, right? If you're having that, what are you having? Having a heart attack. What's the first sign of a stroke? Right? Droopiness, a little, right? I think you're having a stroke. So the first sign of most chronic illness is the illness itself. And yet we know that it takes months, typically years, sometimes decades, for a lot of these illnesses to develop. Yet the first real sign of the condition is the condition. And at that point, it's not too late. We could still treat it, but it's kind of too late. There's so much we could have done for so many years before that happened to actually impact these people's lives. And so what I want to offer to you today is that we need to become doctors. At the bottom there it says doctors of cause rather than doctors of effects. if we could start digging a little bit deeper and start looking at the causes of these illnesses and start intervening sooner in these patients' lives, right? How many patients come in with a glucose of 105 and an A1C of 6.2, and we're like, well, you're not diabetic yet. Come back next year. We'll see if you're diabetic next year, right? We're not, but we have clear signs that this person needs help, but they're not getting the intervention that they need. So, if we become doctors of the causes of these issues, rather than the doctors of the effects of these conditions, then I believe that we'll start making a much bigger dent in that list of conditions. And so what does chronic illness have to do with the mitochondria? Just to simplify it, because I don't have a lot of time, here's what we call the pillars of chronic illness, okay? And it's not that every one of those diseases that I talked about earlier has every single one of these pieces, and it's not like it has to go in this particular order, but just to give you an idea of where we see it coming from. I see that there's some type of tissue damage along the way. Maybe that's a toxicity, maybe that was a metal, maybe it's an injury, maybe it's a stroke, maybe it's a beginning of cancer developing, maybe it's food intolerances that a patient has. But there's some type of tissue damage which leads to a decrease in blood flow, some type of hypoperfusion. And as a result of the hypoperfusion, we can't feed the cells the nutrients that those cells need to get, and we can't get rid of the waste products that are just a natural cause of normal cellular respiration. And so what has to happen? They start to get sick, and they start to get inflamed. And as a result, we get inflammation throughout the body, but primarily we get a lot of GI inflammation and neuroinflammation. As we get GI inflammation, we start to get metabolic changes. We can't break our foods down as well. We become less acidic. We have less enzymes. Our microbiome changes, so we get immune system dysfunction. From the neuroinflammation, we get changes in brain chemistry, synapse ability, from neurotransmitter balances. As a result of all that, we get increased oxidative stress, increased reactive oxygen species. We get further epigenetic and DNA damage, which then leads to further tissue damage. And then that cycle just basically continues. And so somewhere along the way, where we can intervene, most of us do this every day. We need to intervene along this pathway and start making changes well before we actually get the condition that we're headed for. If you know what to look for, you could see the true or false when you evaluate patients at a deeper level. You can see the road they're on. True or false? That was a question. True. Right? And so when we, as doctors here, start to look at that and we start to understand the path they're on, we can change that so much more easily. So Shannon said to me, she said, Jason, I'd love to have you come and present for the IHA conference, but she said, listen, you just can't use the word treat. You can't say you're treating this disease with hyperbaric. I said, Shannon, I don't know if you know this, or I don't know if you guys know this, but I'm a chiropractor. I'm not allowed to treat anything. So I think we're good. And so I use hyperbaric like that. I don't look at hyperbaric as treating disease anyway. I look at hyperbaric as restoring function. Okay? I look at this, in chiropractic philosophy, if you will. We believe that we're self-healing and self-regulating. What does that mean? It means if it's cold, we get warmer. If it were hot, we get cooler. If we cut ourselves, we bleed, and then we clot, and then we heal. Right? When we eat food, we bite it, we chew it, we swallow it, we assimilate the nutrients, we get rid of the waste. We are constantly, our cells in our body are constantly trying to self-regulate the environment so that we could maintain some level of health. And the way I look at this whole conversation regarding the nutrition and the light and the HBOT that we're going to talk about, I look at that as basically, we're just trying to restore normal, healthy function. The body takes care of the rest. And so a quick conversation, this is kind of the conversation I have with patients. It's way too simple for this room, but I'm just sharing it with you because I want you to hear it, just so, maybe if you're in your office and you're trying to explain some of these concepts, they're pretty difficult to explain. This is a pretty simple explanation that I offer most patients. And I say, listen, most of these issues, if you go back to that list of chronic illnesses that we talked about, and then that cycle of chronic illness, what you could say is that basically it comes down to toxicity and deficiency. Either you have too much of something that your body's having trouble getting rid of, and we need to help that, or you're missing something really important, some raw material that your body requires in order to do some sort of function that we're trying to get it to do. And so what we're trying to do is remove people through a continuum of here's toxicity and purity. So we're just saying, hey, how do we just start to move you back towards some level of purity? And here's deficiency and sufficiency. can we just start moving this person away from their deficiencies and start moving them back towards their sufficiency? And as a result, like I said, the body self-regulates and self-heals, so once it gets rid of all the things that it can't handle, and it starts to get all the things that it needs, it just starts to regulate itself. It's quite magical. And so, my head, I think a lot, very mechanically in my head. I like working on cars and boats and trucks. So I look at the mitochondria, I look at the cell from that standpoint. And so just to summarize that quickly, I say, listen, we need some sort of fuel, right? So if your car has the right fuel, gets gasoline, and your engine's working, your pistons are working, your spark plugs are all working, right? You have an oil change, and so the machinery's there. So you put the right fuel in, you have the right machinery, and you have some sort of exhaust system to get rid of the waste, you should be able to move that car from point A to point B pretty well. And that's how I look at our body. We need the right fuel. In some cases, it's glucose. In other cases, it's fat. Maybe it's ketones. We're going to talk about that in a few minutes. But it's also oxygen. Oxygen is part of that fuel system. It is for the car, too, by the way. And then as long as you have proper cellular function, right? Your cells are healthy, or at least functioning. You have all the right organelles, so you can make your ribosomes and all the things that a cell needs, and mitochondria, so you have all the things that a cell needs. And then you have a way to get rid of the natural exhaust that is just a part of normal, healthy cellular respiration. That cell should be able to function and or at least heal if necessary. And this is the places that we intervene, but we don't think about it like that necessarily all the time. But if we can change those fuel sources, if we can increase the capacity for that cell to function or upregulate cellular function or help that body detox properly, we can start to heal. So mitochondria and the HBOT. So before we do that, I want to say this, three separate thoughts. One is, you can't, especially, these aren't targeted therapies. I'm not talking about targeted drug therapies that are trying to influence one particular cytokine, okay? In my mind, what I'm really talking about is offering the body this substrate that it just requires for normal function. And I can't just deliver that right to the mitochondria. I have to give it to the whole body. And so what changes in the mitochondria, it changes in the cell. If it changes in the cell, it changes in the tissue. If it changes in the tissue, it changes the whole organism. And so while we have certain global effects that we'll talk about specifically in the mitochondria, we have to understand that we're really having, local effects in the mitochondria, we're also having global effects throughout the whole body. Point number two, what is point number two? Point number two is that there is overlap, you will see, between hyperbaric oxygen, red light therapy, nutrition, or any other chelation, any other therapies that we might be throwing at our patients for whatever the thing that they need. They're not redundant, okay? So just because there's a similar effect, let's say HBOT might help the mitochondria this way, red light therapy helps the mitochondria in a very similar way, that doesn't make those things redundant. It makes them synergistic. And I believe that in many cases in our office that, patients may have tried this one piece or that one piece here or there. But often is the case when you start to combine these, that the result of the sum of a few therapies having a similar effect is what they needed, and that total sum is much greater than any one of those treatments could be on their own. So, that being said, we'll get into HBOT a little bit. What I won't do, because it's part of this, but we don't need to because you already went through it a few times and I don't have a ton of time. Real basic HBOT mechanism, but just again, these are just conversations that I also have with other doctors who are curious, hey, how does HBOT help this or that? It's also conversations that I have with patients, but it's just a simple way to look at things. So, you've all had a pulse oximeter on your finger, and you all know that sitting here, if you don't have any lung condition or heart condition or anything else that might interfere, we're all sitting here about 98 to 100% oxygenated. And think about that for a minute. 100% oxygenated. Right now, you have all the oxygen you could ever really have. And you need 100% oxygen every minute of every day. It's really interesting, because if you look at other nutrients, many nutrients, we have some sort of storage form for, don't we? So like if you didn't have it for a day or two, you'd be okay. But we need 100% saturation of oxygen, roughly, basically every minute of every day, just to sit here for you to have this conversation with me. And so we could go weeks, let's say, but probably months without food. And we can go a couple days without water. But how long can we go without oxygen? A few minutes. And there's no storage form? It's crazy. It's amazing. And I look at that as a nutrient. So think about vitamin C for a minute. If you don't get enough vitamin C, you get a thing called scurvy. So a deficiency in vitamin C is called scurvy. We want to make sure we don't get that, so we get some amount of vitamin C north of that level. But even further, we might go a little step further and say, well, gee, I don't want to just not have scurvy. I actually want to have enough vitamin C for all the other things that vitamin C does, my immune system, collagen formation, all the wonderful things vitamin C does. So there's like an optimum range that I try to get every day. And then to take that one step further, periodically I may mega dose vitamin C because I have some other issue that requires much more of that for at least this period of time so that I could heal. Maybe like what Dr. New was talking about with cancer, doing drips, or you just might take a few thousand milligrams daily to help your immune system because you're fighting a cold. So I look at oxygen just like that. I would say that there's some amount of oxygen that if you don't get that amount, you get a thing called hypoxia. That hypoxia could be global or it could be local. You could have a crush injury, you could have a stroke, you could have cancer, you could have TBI. Those would be local ischemia. And if you had one of those issues and I put a pulse ox on your finger, it would still say 100%, well, 98, whatever it is, right? Yet, so you have all the oxygen you could possibly have, yet you still have some area in your body that's hypoxic. So hold that thought for a second. So that's if you're not getting enough. Then there's some range that we need that's theoretically the optimum range. And that optimum range for us is virtually 100%, all of it, every day, every minute. But once in a while, we may choose to mega dose oxygen. We might have an issue that says, you know what, this 100% oxygen, it's not enough. I have this TBI, I have this concussion, I have this cancer, I have this crush injury, whatever the issue is, I have this condition that says, I'm getting 100% oxygen, it's still not enough. So I might choose to mega dose oxygen for some period of time to start to fuel that system and let it heal. The issue is if you're 100% oxygenated, how could you possibly ever get more? You can't be more than 100% oxygenated, okay? With pressure. So the only way we have to ever get more than 100% oxygen is by pressurizing the system. Why? Super simple, but we already talked about it, so we'll go quick. Boyle's law, which basically says, if I take a gas this big, and I put a lot of pressure on it, I can make it this big. So as I put more pressure on the gas, I can make it much smaller. And then Henry's law, which says the smaller I make it, the more pressure I put on it, the more I could dissolve into fluid. What does that mean to our body? It means if I take a lot of oxygen and I smush it into a chamber and pressurize that chamber, put pressure on that chamber, I could dissolve it into liquid. What kind of liquid? The plasma of your blood. And now all of a sudden, depending on your setup, depending on the amount of pressure, like Dr. Newbrander was saying, OPM, right? Minutes, pressure, oxygen. We can manipulate those three variables, and depending on your setup, you're now going to dissolve some amount of oxygen into the plasma of the blood. And while you might have a TBI, concussion, cancer, all the things I was saying before, where oxygen can't get to that tissue because the capillaries are damaged. If capillaries are damaged, red blood cells can't get there. If red blood cells can't get there, oxygen can't get there. Unless you dissolve oxygen into the plasma of the blood, and plasma goes everywhere. So now all of a sudden you have this tissue that was starving, hypoxic, and now you're fueling it with just as much oxygen as it needs. And so that's how we get the healing response through HBOT. What are some of the benefits of HBOT? So this is just some of the short-term benefits. Again, we've talked about this a lot this weekend, so we can kind of go quick through some of this. But you get an increase in antioxidants. And some of those antioxidants that are released help offset some of the oxidative stress that HBOT actually creates. So increase in SOD, superoxide dismutase, and glutathione peroxidase, increase in rate of oxidative phosphorylation, which we'll talk about in a minute, some vasoconstriction, decreased inflammation, energy balancing, increased perfusion, obviously decreased hypoxia. But long term, even more magical, we start to get regulation in the immune system. We get changes in the cytokines, we get balance between neutrophils and macrophages. As Dr. Harch likes to talk about the epigenetic effect, and maybe most of HBOT's effect is in the epigenome. We get neuronal regeneration, we get wound healing, but it doesn't have to be a diabetic ulcer that isn't healing for months on end. Aging is wounds. Aging is cumulative, small, cumulative wounds over our life that aren't necessarily always healing quite as quick as we would want, not as quick as they were when we were 8 or 10. And so if we have a tool that we could actually help heal these micro wounds cumulatively over time and heal them as they're occurring, we could have a huge effect on the aging process. Antioxidant release, we talked about angiogenesis. Not only are we going to dissolve oxygen into the plasma to acutely treat whatever issue, whatever tissue is actually hypoxic, or long term, we're going to build new circulation. We're going to build new capillary beds that are ultimately going to allow red blood cells to get to that tissue, which means that we don't need to continue to do HBOT for that particular thing, because now it actually has a blood supply on its own, and it can get the oxygen it needs to get rid of the waste that it doesn't, and it could heal. We're going to get stem cell release, not just out of the bone marrow, but on the central nervous system, and it also helps kill anaerobic infections. How many? So many of our pathogens, right? We have more bacteria and microbes that live in and on us than we do that have cells that make us up. So our relationship with our microbiome is really important for our health. And so with hyperbaric oxygen, most pathogens are anaerobes. So if pathogens are anaerobes and we're putting them in these high oxygen environments, that helps to kill some of those, or at least make it really uncomfortable for them to live there. At the same time, most of the good bacteria, the probiotic that live in and on us, are aerobes. And so at the same time we're feeding and fueling the healthy bacteria, we're making it really uncomfortable and potentially killing some of the unhealthy bacteria that live in and on us. What does that have to do with the mitochondria? Well, it turns out oxygen might be a rate-limiting factor for oxidative phosphorylation. In other words, if we had more oxygen available, we can crank out more ATP. That's huge. In Israel, they're doing some tests, some research with dual tasking. So they're taking patients and they're basically having them do complex cognitive and motor skills simultaneously. It's pretty hard for us to do that. And so their hypothesis was, well, maybe it's just that the only reason we use such a small part of our brain is we're already using the brain uses about 20% of glucose, 20% of the oxygen that we absorb every day. And maybe it's just a fueling issue. In other words, if we had more fuel, could we be capable of more? Could we upgrade our RAM to be capable of performing more complex, more tasks for longer periods of time? And so what they're doing is they're dual tasking these patients, and they're exposing them to hyperbaric oxygen, they're dual tasking them again, they're watching them on functional MRI, and what they're seeing is they're capable of more. And so if they're capable of more, what they're saying is basically, as I had more oxygen, I was able to do more. So it's a rate-limiting factor for mitochondrial function.
Yeah, that study listed in
I don't, but I can get it for you. They increase mitochondrial density. So the mitochondria, especially in the brain, but pretty much everywhere, mitochondria recognize the increased oxygen load that it's being exposed to. And as a result says, hey, we can't just sit here and let all this oxygen go to waste. We need to multiply. So it increases its own density to say, listen, if there's so much more oxygen available, let me have more of me so that we can make more oxygen. And then, of course, it also helps with mitochondrial efficiency. Red light. Does anybody in here use infrared, red, near infrared, and all this kind of good stuff? Yeah, good, cool. Okay, what does that do with mitochondria? Red light, we're just going to talk about light in general for just a moment. So that's the sun. Made me think of the cruise. So sunlight is white light, and white light contains the full spectrum of light, right? All visible light is contained within sunlight. Just to show a picture of that, basically everything around us is frequencies and wavelengths. There's X-rays and MRI and FM radio and TV and GPS, everything, right? So all of these frequencies are bouncing around us all the time. That's a whole other conversation, potential health hazard. But within that small range of frequencies, there's a tiny piece in the middle called visible light. So it just happens that we can't see X-rays, but we can see the color of red or blue. So within that is visible light, and visible light is the spectrum of blue, violet, let's say, to red, but really we'll just say ultraviolet to infrared. So just a little bit further outside that spectrum. And we know that human bodies are very sensitive to light. So we think about that in terms of, let's say, getting a tan, right? So you expose your skin to sunlight, let's say, on the back of the ship in between lectures, and you should have some change in your skin, right? So we know that we're light sensitive, but we also know things like we make vitamin D from UVB, right? We know that certain frequencies of ultraviolet light are actually very antimicrobial, antifungal. And so we're starting to look at the light spectrum therapeutically. Again, if we want to talk about the toxicity and deficiency thing, to some extent I might say that we wouldn't need as much therapy with light if we still had the same type of exposures to sun. But like many things, at one point, let's say in the 70s, raise your hand, I want to know, who went on their roof, lathered in baby oil with a reflector? Come on, be honest. I know you did. So with iodine, I never did. That's even, wow, you're hardcore. So we know that the skin is sensitive to light, and we know you could become a little sun toxic, right? That's a little too much sunlight. Now what are we doing? We're avoiding the sun at all costs. It's like this crazy ball of fire in the sky that we should never be exposed to. We're covering up all the time. When we're not, we're covered in sunscreen, which has its own toxicity issues potentially. So, now we're sunlight deficient, I would argue, and as a result, we see pandemic amounts of vitamin D deficiencies, amongst other things. So, but now it's becoming a therapy. So now we need to supplement light to make up for the deficiency we've created by avoiding the sun, which actually had all of it in there in the first place. So, so we're using UV therapeutically as an antimicrobial. They're starting to do research on green light for insulin sensitivity and also for skin health. But we're also using red, near infrared, and infrared. It's just a range of frequencies therapeutically for other cellular recovery. And so globally, we're seeing things, they're doing some research, this guy Kim, I forget where he is, he might be in Japan, but he's doing red light therapy directly to the skull at 40 hertz, and he's seeing changes and shrinking of amyloid plaques and tau tangles. It's known to be a general anti-inflammatory agent, helps to stimulate properly CNS, so we're getting better stimulation in our synapses in our brain, wound healing in local areas at high dose, pain modulation, and then we're also starting to see changes in cholesterol synthesis and also insulin regulation. Also, like hyperbaric, and I forget who may have said it earlier, it might have been Dr. Rosignol, or I'm not sure, but the dose is the issue again. So just like in HBOT, the dose is an issue. We don't really have a great formula for saying this is the exact amount of pressure, amount of oxygen, and know that they're getting the exact amount. I think we're having the same issues in terms of red light. There's so many sources of red light, different power densities at different frequencies. So they're studying kind of all of them in little pieces, but not necessarily narrowing that down into the exact amount, but it's coming. What does it have to do with the mitochondria specifically? I would say we can narrow it down to these three things: cytochrome C, reactive oxygen species, and nitric oxide. Nitric oxide has a lot of roles, but particularly, as we increase oxidative phosphorylation, sometimes nitric oxide builds up inside the mitochondria and actually clogs the mitochondria and decreases its efficiency. And so, as it turns out, red light helps to push that nitric oxide outside of the mitochondria, allowing it to do what it needs to do. It also increases nitric oxide release globally, so we get that endothelial response that we were talking about earlier, which is basically vasodilation, so increasing blood flow, thereby increasing oxygen. Reactive oxygen species is the same thing as I said with hyperbaric. You're basically creating balance. So yes, some of the benefits of hyperbaric is absolutely the oxidative process. We have to irritate things a little bit to kind of get the response that we want. At the same time, we don't want the oxidative process to get out of hand. And so we want to have modalities that help balance the inflammation while we're creating the inflammation, so we don't go too far either which way. But the most important is the cytochrome C. Who here uses CoQ10? Right? Do you know why I use CoQ10? Do you know where it fits in the mitochondrial model? So, you guys see anything here? Oh, there we go. Right, so here's complex 1 and complex 2 on the electron transport system. So they're accepting the electrons from NAD8 and FADH2. You need to get from complex 1 to complex 2. From complex 1 and 2 to complex 3. And so there's a mobile carrier. You have to get from 1 and 2 over to complex 3. CoQ10 is that mobile carrier. And so in many cases, if you're deficient in CoQ10, you have a hard time continuing the process of getting those electrons down the road they need to get you in order to get to oxygen. Well, just like you would want to use CoQ10, because it's the mobile carrier to get from complex 1 and 2 to complex 3, cytochrome C is the mobile carrier that gets it from complex 3 to complex 4. Complex 4 is ultimately where it meets oxygen, and it's the last electron acceptor. And so if we could stimulate cytochrome C the same way we stimulate CoQ10, we can move those electrons down the chain more efficiently. And so as it turns out, cytochrome C is a chromophore. It's very sensitive to certain frequencies of red light. And so if we give the body, especially a whole body treatment, have you guys seen whole body infrared stuff? So if you start giving the whole body decent doses of certain frequencies of red light, you could start to actually stimulate cytochrome C the same way you would using ubiquinol to change the mitochondrial function. So it's a pretty amazing tool, mitochondrial function-wise. So, mitochondria, ketones, and fasting. Who here uses ketosis, fasting? Fasting? Good. All right, cool. So, what does that have to do with the mitochondria? So much. nutrition is a huge part, I think, of probably most people's practice. And I think all of these diets are great. Gluten-free, dairy-free, FODMAP, specific carbohydrate. They all have their place. They all have their purpose. All of them are basically trying to remove, again, toxicity and deficiency, right? So if we can remove certain foods that we know are pretty inflammatory or toxic for whatever reason they are, or if we could start to nourish the body so we're avoiding certain foods because we know that they're just basically empty calories. You know, a lot of these diets are much better than the SAD diet. You guys know the SAD diet? Standard American diet? That's right, yeah, exactly. So any of these are better than that, but there's a reason to use ketosis and fasting. Because it's different. Why? It's different because, one, all those other diets, you're basically changing the macronutrient profile. You're removing gluten, let's say, you're removing dairy, or you're eating specific complex carbohydrates, trying to avoid some of the simple carbohydrates. But in all of them, you're still getting a high enough glucose injection at every meal to really never burn fat efficiently. And so that's one of the biggest differences with ketosis, is you're changing the body primarily from burning glucose to primarily burning fat. The other really important thing about ketosis is it's measurable. It's like, well, how paleo are you? Are you 100% paleo? Are you 80% paleo? Are you 100%? And who knows, right? Our patients could try to be doing a good job. They're telling the truth, but you know, maybe this thing snuck in or that thing snuck in. We can't measure that really. Ketosis we can measure. We can measure your urine. We can know how many you're wasting. We can measure your blood, so we know how many you're building. We can measure your breath, so we know how many you're using. And so it's super objective to understand and just educate patients to say, look, here's how your body's changing as a result of this diet that you're doing. And so we use ketosis and fasting both sometimes together, sometimes separately. Sometimes we do one or the other depending on the patient, the case, and their issues. But it's a pretty special process. And so ultimately, what is it doing that's so different physiologically than pretty much every other diet out there? The simple term. So unlike Dr. Rosignol, whose first talk he said there won't be a quiz, there will be a quiz after this, so you better memorize this. Sorry. So primarily, we learn a lot of glycolysis, Krebs, and electron transport based on glucose metabolism. And so in that scenario, you're bringing glucose into the cell, you're breaking it down, you're making a couple ATP, you throw it into the mitochondria, you mix it with oxygen, and you're making 32, 36, depending on which book you want to read, I guess. So what this is saying that you need to not eat carbohydrate for periods of time. By the way, you're designed to not eat carbohydrates for certain periods of time. And we adapt really, really well to that. In fact, our ability to adapt in general is synonymous with our level of health, I would argue. So this is just creating dietary adaptation. And what we're going to do is we're going to not feed the system carbohydrate for some period of time. Some people go to a high protein diet. I would still say, basically high fat, moderate to low protein, but very low carbohydrate is the proper way for a few different reasons. But what we're going to do here is we're going to basically stop feeding the system glucose. The body's going to release glucagon and epinephrine. As a result of the release of glucagon and epinephrine, we're going to start getting fatty acids mobilized from adipose tissue into our blood supply. Now, those fatty acids can't free float. They have to be bound to albumin. Why is that important? Well, until recently, we didn't think the brain was capable of running off of fat, because you can't get fatty acids bound to albumin past the blood-brain barrier. And so if you can't get fatty acids bound to albumin past the blood-brain barrier, you can't possibly run the brain on fat. And so we would have thought that the whole brain runs on glucose exclusively no matter what. But what happens is you get so much fatty acids, long chain, medium chain, short chain fatty acids going into the liver, you have so much acetyl-CoA. It's the same substrates regardless of the process, glucose or fat. But you get so much acetyl-CoA building up inside the liver, mitochondria, that the Krebs cycle slows down, it becomes sluggish. And so it starts to realize it's not getting enough glucose, so it actually makes its own. So part of, the amazing thing about the liver is the only the only tissue that actually cannot burn ketones for fuel. And so it actually goes through gluconeogenesis. It takes those fats that it was burning, or trying to burn, and it shunts it back up the pathway, back to pyruvate and up to glucose, because it needs to fuel itself for function. And so it does half of it, not even half, but a small percentage goes through gluconeogenesis to start feeding that system, and the other part goes to ketone synthesis. In ketone synthesis, you're basically just packing acetyl-CoA together. So you've already broken it down, right? You've already taken it from a long chain or a medium chain triglyceride, and you're already broken it down to acetyl-CoA, so it's already like an energy packet. It's like ready to go. But now you're going to fuse two acetyl-CoA together, and you're going to send them back into the bloodstream. Why is that important? Well, ketones are water soluble. And because they're water soluble, they don't require albumin to go to the brain, and so they free flow to all tissue. So we can get ketones, kidney prefers ketones, muscle tissue prefers ketones, and as it turns out, if the brain had a choice, it preferentially binds ketones over glucose. It's just we have to give it a chance. So, you have to keep the glucose levels low enough, long enough, to actually get this response. You know, we've taken a lot of patients through this process, and they might, you know, be good for a few days, right, and they have like a cheat meal here or there. You know, we call it fat adaptation, right? Fat adaptation means that you've done this long enough where you're legitimately, your body now knows how to make ketones pretty efficiently. If you don't get to that process, what happens is people go in and out of ketosis all the time. And what you'll get is you'll get patients who measure urine because it's cheap and it's easy and it doesn't scare them. And they say, oh, I'm in ketosis. I have all, you know, I have you guys look at the ketone sticks, urine strips, and so, oh, it's really purple. It's the most purple it could be. But if we measure their blood, it's not necessarily building in their blood. And the reason for it is because the body's not ready to use it as a fuel source. So you're building ketones, but you're getting rid of them. Ketones in your urine are discarded ketones. They're not used ketones. They're perfectly good, but the body's getting rid of them because it doesn't know what to do with them. As you become more fat adapted, the urine ketones actually start to go down. And then people get frustrated. I used to be dark purple, now I'm just getting this light pink. It's because your body's actually starting to use them. And if you went and measured blood, which is what we recommend for most patients, if you measured blood ketones, you would start to see as the urine ketones are going down, blood ketones are going up. If you took it a step farther, you could actually measure your breath, the acetone in your breath. And as a result, you could say, well, how many ketones did I actually use? Because it would show you the metabolism of ketosis. That's the quiz right there. Let's memorize that. So, that's a summary. We did that. This is in your book. It should be pretty accurate. So, these are just good charts. I think they're useful for you to learn. But what it shows, you know, let's say what this one shows, which is really interesting, is that infant metabolism is a very high ketosis. It only takes about 3 or 4 hours of fasting for an infant to go into ketones. Actually, mother's milk is actually pretty high in medium chain triglyceride. But what that shows is how many hours and how many days and age ranges for when ketones would actually kick in. The top one up there just shows you that basically you need to get glucose to come down. It takes about 4 hours to burn dietary glucose. But it takes like 12 hours to get rid of your glycogen. And your body will burn through all your dietary glucose and all of your glycogen before it ever even considers making a ketone. And so for a lot of times, you need to be in this process for a good chunk of time before your body's going to really adapt to that process. That's the most important part, I think, of ketosis. You can, Cahill study, which I don't have a ton of time for, because I don't have a ton of time for, right? Does anyone know what time?
You have 5 minutes.
Okay, that's not enough time. So Cahill study, they will never repeat this in humans probably, but they basically took, I think it was 10 healthy adults, they fasted them for 40 days, they measured their acetoacetone and their beta-hydroxybutyrate, which are the two main ketones that our body makes. So what they basically saw was that over time, through fasting, their ketones started to rise and eventually leveled off. Their glucose plummeted, but then also leveled off. And I think it was Dr. New who talked about in some animal studies that they're still continuing to do, they basically then injected them with 20 units of insulin. And so their glucose plummeted. I think the average was the upper 20s. And there was zero change in cognitive or physical abilities. I can tell you that I do measure ketones and I do measure glucose in myself, and I've had many times, short spits, but like usually my glucose is around 72 to 74 in a fasted state. But I've had mornings where I woke up and my glucose was 30, 28, 30, 39, 42. And those are some of the mornings I wake up, I feel the best. And I think, wow, why am I out of ketosis all of a sudden? But it's not. My glucose is that low, but my ketones have skyrocketed. And so if you measure that, you start to understand the relationships between glucose and ketones. It's pretty amazing. What are some of the general benefits of being in ketosis? Well, so obviously some fat loss because you're burning your own body fat as your main source of fuel. You'll start to see some hormone balance for sure as a result of that. You get reduction in inflammation. For the folks who deal with a lot of neurologic issues, you see amazing balance between the GABA and glutamate. And so if you're looking to reduce glutamate and improve GABA and improve that relationship between the two, ketosis is amazing for that process. And then also improved central nervous system metabolism. Specifically on the mitochondria, again, it's very normal for infants. It would be normal for us, except we went through a life of never going through that process, right? In fact, we were told to eat every 3 to 4 hours, eat 6 meals a day. For how long have we been saying that? And so what's interesting is if you measure glucose and hemoglobin A1C only, you would see that as a result, if you're not crazy eating donuts and everything every day, you would see that your blood sugar curve would be more normalized eating every 6 hours. 6 times a day, every 3 or 4 hours. But if you measured insulin in that same period of time, what you would see is while your glucose looks much more normal and a healthier curve, and maybe it helps keep A1C from going out of control, your insulin is all over the map. And so what we're trying to do is we're trying to say, listen, we need both, right? For these people, especially diabetics, we need both of these systems to be balanced and healthy. We need the sugar system to be down, and we need the insulin system to also be down. So you get a lot of that with being in ketosis. It reduces the oxygen requirement. So all of a sudden, you don't need as much oxygen to get the same work done in the mitochondria for ATP production, and you have less carbon dioxide as a waste product. So all of a sudden, just like in a car, we're cleaning up the fuel as a way to reduce emissions, right? That's basically what ketosis is doing. We're cleaning the fuel. Fat burns much cleaner than glucose ever could. There's much less waste, and as a result, the mitochondria could become much more efficient at ATP production. And again, we get increased mitochondrial density. The body says, oh, look at all this extra energy I'm making. All these ketones are just floating. Right? Your body doesn't know how many to make. It just starts making ketones when it's appropriate to make ketones. And all of a sudden, most people in ketosis have enormous amounts of energy. I haven't eaten all day, can't you tell? But because of that, you're basically throwing so much excess energy into the system. The body wants to use it. And so it makes more mitochondria as a way to use that up. We basically talked about that. It's in your notes. Is it forever? I mean, just a summary. No. It could be. That's probably not ideal for most people. It's not necessarily the easiest lifestyle. But what I would say is while you're doing other dietary treatments, you are using paleo, you're using FODMAP, you're using specific carbohydrate, all of which are important, you still, if you actually got a patient to go through this process, you'll keep it. And so maybe you don't have to do it forever, but after you do it for a good chunk of time, you can go back to whatever other diet worked really well for that patient. And then maybe once a month you do a little bit of a fast, or maybe quarterly you do a month of ketosis, or one of these kinds of things, but you keep your toe in it so that you keep the benefits of having gone through that process in the first place. And what that does is it increases your capacity for carbohydrate. So I can tell you most of my patients, myself included, my carbohydrate tolerance, I can eat many more carbs today than I could 3 or 4 years ago and still remain in ketosis because my body prefers it. So the glucose that I end up eating in whatever form it is, it's like jet fuel that burns right up real quick, but at the same time I'm able to maintain the level of ketosis because the body is used to it and it actually does prefer it. Summary. Okay, restoring function versus treating illness. We talked about that, right? We're not treating these issues. We're just trying to give the body the things that they need to heal. And I would argue that these are 3 really important ones. We need to do really good detective work. If we can go through a patient's life and history, figure out where their toxicities are, where their deficiencies are, and start getting rid of the things that they need to get rid of and helping get them the things that they need, we can start changing health. Plan nutritionally for restoring that. Ketosis, red light, hyperbaric, fabulous. All good. Synergy. So I'll basically just end with this. What I said before is I said, they're synergistic, right? They're not redundant. Think of the mitochondria as, it is basically a bacteria, right? So just think of it as a living organism. And just think that we could have mitochondrial dysfunction. Let's just say your mitochondria is working at 70%. But if we had twice as many, wouldn't that be good? Or let's say it's working at 70%, but if we could make them more efficient and get them to 80%, wouldn't that be better? And so here are 3 different modalities, and there are others. We'll use CoQ10 as one. So there's 4 different modalities that all work together just to say, here's some sort of mitochondrial dysfunction. How many ways can we improve it? How much more efficient can we make them? And can we make them have more so that even though they're not super efficient, when I double the amount, I increase the amount of energy that I was making. And so what I'm saying here is basically, you could read them, but we're adding certain nutrients basically to affect the mitochondria. We're changing the fuel source to make the mitochondria more dense. We're changing the fuel source to make it more efficient. We're stimulating the mobile carriers, CoQ10 and cytochrome C, to make sure that we're getting continuation of the electrons through the electron transport system. We're stimulating nitric oxide to get it out of the mitochondria because it clogs it up, but expose the tissue to more of it so we get better blood flow and oxygenation. We're balancing the reactive oxygen species. Basically, we're balancing the oxidative process within our body, so we're helping to deal with the oxidative stress of other therapies that we may be doing. And at the same time, we're then providing an increase in oxygen as that last electron acceptor so that we could basically make as much ATP as possible. That's the plant analogy, which is fabulous. We just don't have time to do it, so we'll do that next time. The end. Yes, thank you.
I'm interested in how, if you're looking at sort of this 3-prong, using these different things and managing
Sure.
ketosis, do you change your therapy when you get kids or these people that are going into ketoacidosis because it's, they're not adapting well?
Sure. Are you having that experience? Are you measuring ketones in these kids? Okay. So absolutely. So the question is basically about ketoacidosis and using multiple. It's not like I don't have a protocol that says for this condition I do this much red light in these places, this much HBOT in these places, and this detox with this diet. We take each case as they come. We do as much work as we can to figure out their story. We monitor levels, things like that. I think typically, if they're getting into ketoacidosis, that's an issue. You could definitely dial that back. There are, I'm going to say, levels of ketosis. You can increase certain carbohydrate intake at certain intervals to try to get those levels down. The second that your body gets glucose, it converts back to glucose.
So you do primarily just dietary management then for ketoacidosis. You're not altering other therapies to try and bring that down.
Typically not. Yeah, typically we would manage that through the diet itself. Yes, sir.
Are you doing red light therapy as total body red light? Are you doing eyes, head? What are you doing?
So we do all the above. We have a couple smaller handheld lasers where we're targeting, let's say on the injury side, an elbow or a knee, on the brains, directly for brain stimulation or inflammatory issues like that. But then we're also doing full body, moderately high dose red light for purposes of things like that.
Are there any dangers of using the red light with cancer patients?
The studies are mixed on that. My take, it's not that new. I mean, there's probably more studies on red light than there are HBOT. But I think it's going to turn out to be kind of like, initially with HBOT, we talked about it about a couple hours ago. Initially with HBOT, everyone said, no, you can't do that. Oxygen feeds cells. If we feed cells, we're going to feed cancer cells. And that turned out not to be the case. And so what I think is going to happen is, cancer cells don't utilize the electron transport system, right? They're basically fermenting lactate, right? We talked about that earlier. So, a lot of these cells are broken metabolically anyway. And so I don't think we're going to see that there's any negative effect on cancer. Depending on the distributor, the company making them, there's a mixed stance on that currently. My own opinion is that I think we're going to find out that, the same way that hyperbaric feeds healthy cells what they need while killing cancer cells, I think we're going to find out that red light feeds healthy cells what they need, and at the same time makes it very uncomfortable for cancer cells. It's the same thing that ketosis basically kills cancer cells and feeds the healthy, so we're trying to, and even if you're using traditional therapies, let's say with cancer, you're using chemo and radiation, they're doing plenty of studies with ketosis and HBOT, right? They're mixing those. But what we're going to see is that we're saving, even if that means that we could tolerate, in some studies, they're increasing the radiation dose because patients are tolerating more radiation because they're getting healthier. And so if that targeted therapy is that important for that patient, then maybe that's great. So we're making them healthier, their healthy tissues healthy, they're gonna survive the treatment, now we can increase their dose. Or in other cases, maybe they don't need as much of that traditional treatment because the rest of their body's getting healthier and we're finding balance and regulation through just helping heal the tissue.
Yes, sir. Is there a particular blood level of CoQ10 you're shooting for?
I actually do not measure blood levels of CoQ10, so I don't have an answer for that, but I'm sure we have it in this room. Anything else? All right, I'll be here for the question and answer too. Thank you. Thank you.